It's good? It's 5 minutes, so we will have to start. It happened in my favorite course, but I think if we made the hurricane, I think we can do anything. So this is nothing, we'll manage. Okay, we'll start the breast. We have 5 days to do the breast, which I told you before, this is my favorite course. I am board certified in breast pathology, and I told you before, if you're gonna collect boards, go to pathology. Each fellowship is a board, a 5. So, so breast, my second favorite actually was the pancreas. Please pay attention to the review, really. You wouldn't miss anything. So I have this course and I have another course with me. You know that or you don't? You don't? I have one more. This will be the male genitalia, which will be dealing with prostate and all the, this is a part you're not like. See, there's some people coming to wave to them. And the testis is like the ovary for female. So all these diseases you want to throw in the ovary, we'll go through to the testis. But I'll make a nice diagrams, moving stuff. So it will help you actually do good revision even for the ovary. So let's go for the breast. And the breast, I divided into 3 major subjects, not lectures. The first 2 subjects are big. The third one is kind of review. The first one will talk about a reminder quickly to structure of the breast, so we are ready to understand. And we'll talk about the inflammatory condition and some of the benign neoplasm, anything short of malignancy. We will go through it, and this second will be devoted entirely for all the malignant neoplasm of the breast. The third one will be about all of these prognostic factors, epidemiology. Very easy, but very rich in exams. So we'll go through this. Before we start this, anybody has any question? No questions for now, okay? So we will go through the other thing because my phone is being used now. We are supposed to finish at 1:40. So if somebody alert me 2 minutes before, somebody will tell me.
I will.
Enough, Dr. Aziz.
Okay, I'll put it
Okay,
on.
so we'll talk about anatomy, histology, and some developmental disorder. This objective is the entire course. We'll talk about the epidemiology, and this will be in the third talk. We'll cover the inflammatory diseases you need to know. We will learn about all breast condition, benign, especially this fibrocystic change. And by the way, in our days, when we were in medical school way back in the 70s, it used to be called fibrocystic disease. This is how we learn medicine. And now, of course, it's not a disease, it's a change because it's not really a disease. Then we'll talk about everything we need to know about malignant tumor, and we will learn about prognostic factors and so on. You know what I'm saying here? And as I told you, my minimum really is Robin's questions. And as I told you, in the first exposure to Robin, I repeat this all the time because I don't want you to miss it. Don't take it as testing, take it as learning. Read it when you start. The other thing, I know we all use Bathoma, or most, let's say, very popular. I like him a lot. And when he shines, I tell you he shines. Don't miss Bathoma in red blood in general. Red, white, bleeding, all blood. With Bathoma, don't miss a minute. Breast, I told you with the pancreas, he just said hello to you. But I told you stories. Breast, take as much as you can from Bathoma. But obviously he is not a clinician in breast. So if you have anything that can confuse you a little, please email me. But take Bathoma with the breast as another, but instead of 1 hello, make it 3 hello. But still a hello from Bathoma. And so we'll talk about histology quickly. And it's important to know, let's start from out getting in. Those are the ribs, and of course the ribs is like sticks. When you cut through them, you get this oval structure. And in between, we have the intercostal muscle. Then next to them, two big muscles. One big, and this is immediately behind the brevis pectoralis major and behind the pectoralis minor. Then the white line here is the fascia. And this is important, this image, because when we have, I'll give you just one slide about breast reconstruction, augmentation, or maybe augmentation, I'll give you just a quick idea about it. So the location of the implant, we'll learn about it. Breast, we talk about the breast as a fibro-fatty tissue. This is when we talk about the breast. What we mean by fibro? Fatty is obvious. You see all of this yellow is fat. So the breast is loaded with fat. And fibro, we refer to fibro to the connective tissue and the breast tissue itself. So when we say breast tissue, somebody has a book, maybe they can borrow this, because they don't have a pad for the mouse and it is difficult. No, this is killed it. Yeah, okay, we'll do our best. So when we say fibro, we are referring to the, we'll try that. You know, Mr. Bathoma himself. No. Thank you, good try. We'll manage. So I want you to understand, fibro means the fibrous stroma and the breast tissue itself, we consider it fibrous. What I want you to know is how we do screening for the breast. What is the test we do screening? It's called what? Mammogram. Okay, in mammogram we are looking for what? Why do ladies do mammogram? You have to think always like why, always, you know, it's not, oh, you do mammogram. No, you do mammogram, you're looking for what? And if you find what, you will do what? So I want you to know that, and for mammogram, really after this course in a week, you will learn two things, and I promise, two things. And why you learn it? Because first semester already know this now. So at the moment, they know it and they don't. And these two things is number one, when you look at a mammogram, you'll be able to tell if this is a young person or, do I say old? I don't, I say not young, okay? So, and here we'll just define it as premenopausal, post-menopausal. So you will be able to look and say, oh, this is younger lady. No, this is not a young lady. You will be able to do this. Number two, you will look at calcification, and believe it or not, you will be able to say this is likely benign or likely malignant, believe it or not. Speak to any first semester student, they will tell you that. So this is only the two things I promise you that we will have. So what I want to tell you is when you do a mammogram, when it go through the mammogram is a kind of imaging, like whatever X-ray or whatever imaging. When they hit the fat, they will get reflected or go through the fat. They will go through the fat. So it will appear opaque or translucent. Translucent. It will appear black. But when you hit any fibrous tissue or breast tissue, it will get reflected. And the more dense it is, it reflected more. So the dense breast tissue or cancer or calcification will appear white. So you got this concept? Okay, I will get your attention and I know how. This can be a subject of questions, not only here in the USMLE, believe me, so now we have the attention. When you go through fat, it's translucent, it's dark. When you go through tissue, including cancer, including calcification, it gets reflected, so it appears white. Okay, so let me tell you, when you are young, and young we said premenopausal, you think you have more fat in the breast or more breast tissue? Young, more breast tissue. And with older you have what? More fat or more breast tissue? More fat. Why? Because you have decreased estrogen. Makes sense, right? But this is important. You know why? If you're taking mammogram of not a young person, you're expected to see in the breast lots of what? Not young. You're expected to see lots of what? Fat. Fat will appear what? Translucent. If there is cancer, cancer will appear what?
White.
Okay. When you have a young lady and younger lady, especially dense breast, you have lots of breast tissue. okay? So it will appear white or opaque, right? So the question here, and this is an exam question, now everybody attention. Which is easier to find cancer by mammogram, in a younger person or older person?
Older.
You got the idea? I have a slide. Don't take notes, I have a slide. But this introduction, why you are doing this. So the breast consists of this lobes, this sacs, each one, see lobule, this is a lobe, each one of the pink, and then lobules, this round structure. Those has the lobule supposed to secrete milk when needed, or if there is no pregnancy or lactation. The monthly change because of estrogen, progesterone, you have some secretion. So, but the main function really is the lobules is to make milk when needed. Then they have to be squeezed to go to the little ducts, and the little ducts unite to make this large, what we call lactiferous ducts. And if it is time for secreting milk, so you have what we call lactiferous sinus. This store the milk until the baby will suck on the nipple and express the milk. So this is just a general principle of the structure of the breast. There are eventually you have about, they can vary from 16 to 21 major lactiferous ducts, and this is getting all the secretions from the alveoli to be excreted out in the nipple. Now, when you have the alveoli, the alveoli is lined up with what? Epithelium, right? And we have milk. So the milk need to go outside. So what how can this happen? Oh
Myoepithelium.
wow, you are good guys. So it's myoepithelium, and we'll get a slide into this. That's why there is a rule. 2 layers breast lining the duct or the alveoli. As long as you have 2 layers, this is more likely benign or malignant? Benign, because we have 2 cell type. But if we, for any reason, have only 1 layer, 1 line, this is most likely benign or malignant? Malignant. Why? Because this means that 1 line colonially proliferate on the expense of the other. We'll come to this. So let's have, one thing here, I told you the old and young, and how can they are different in the mammogram, and I'm telling you, we'll have a slide for that. You will have a mammogram, and you will be requested to guess the age, and you will have a mammogram, and you will have to diagnose benign, malignant, or I don't know. Of course, there is no score for I don't know. Another thing here I want you to know is there's difference between man and woman breast. So let me ask you, can man have breast cancer?
Yes.
Yes. Man, no lobule. And why no lobule? What is the function of lobule? Does the man need to make milk? No, thank God, man has a wife, so no, the man doesn't need to make milk. So this is very important. Men don't have alveoli, they don't have lobular. The 2 most common cancer in breast is ductal and lobular. This is there are many other, but this is the 2. Somebody asks you, oh, I got breast cancer. The next question will be, oh, ductal or lobular, the commonest. So for male, what kind of cancer male will have? How about lobule? Okay, because there is no lobules, okay? So just a reminder quickly here, when you get a section, this is what you get. You get circles, you get oval stuff, you get lines. I have no idea what is that. But I can remind you of the 3D. Those are tubes. And you are cutting through it. So it depends. If you are cutting like this, you get a circle. If the cut is oblique, it's like that. If your cut happen to be here, look like that. And you have to understand, you are taking 1 cut of many tissue. Meaning the ducts, some like that, some like that, some like that. So when you cut, you go through all the scenario. And that's why this is what you see. Another one, because this is what you see in a section. You have no idea what it is. For example, you see this and this and this. And think, oh, those are 3 ducts. But actually, if you look here, they are only 1 duct. Because if you make the cut here, this is the first circle. Then the cut going here, it will make another circle. Then the cut here is making another circle. So see here, 3, but only 1 duct. And so spend a minute, please, to see how everything coming from, because this is what you see. This is what you see. This is a very important slide because this is dealing with benign and malignant and basics in breast. And what is this? It's talking about the 1 layer and 2 layers. So what we are talking about here, we're talking histology of breast, and breast has epithelium and stroma. And the epithelium lining the duct and the lobules, meaning the blue is the epithelium here. So this is a duct, and we know it's a duct because it's a tube. So the epithelium, which is a blue, lining the inside of the duct, and that's why it's called the luminal cell. Luminal because they are close to the lumina. And in the lobule, when they get to the lobule, they become purple here to fill the sac of the lobule, and when they start to secrete milk, the milk can go out through the duct. So the second layer, we see here the brown, the myoepithelial cell, and it makes sense because when we want to squeeze any secretion, so this is a myoepithelial. The myoepithelium also goes around the lobule here, as we see it become orange here, just for clarification. The green cell here is like anywhere. There should be a stem cell or progenitor cell. So this is from where any cell can come. This is diagrammatic. When we take it in a section, it appears like that. And all you want to know is it 1 cell layer or more than 1 cell layer? And why I'm saying more than 1 cell layer? Because you have hyperplasia, you have increased number and so on. So take it as a principle. 1 layer versus more than 1 layer. 1 layer likely carcinoma, and more than 1 layer likely benign. But let's clarify it more here. 1 layer mean actually invasive, and I explain why. 2 layer means benign or non-invasive. For example, you see here in this one, you have all of this blue cell. This blue cell can get crazy, and the crazy usually change the nuclei. The nuclei can get bad. I mean, you have complete cancer here, but still the myoepithelial is there. Somebody hasn't asked me a question yet. I was expecting it. And the question is, where is the basement membrane? Remember that the whole significance of invasion is the basement membrane. And why the basement membrane will define the invasive? Because there is access to what? Let's call it vasculature, blood and lymph, right? Because we know carcinoma like lymph more than blood, sarcoma like blood more than lymph, but they can do both. Okay, I'll change the color especially for this point so you remember, because this is important, and that's why I'm changing the color. Think in the breast, different than any other organ, specifically in the breast, maybe salivary gland when you get anything that has strong myoepithelial cells. Think of the myoepithelial cells and the basement membrane are almost the same thing. They are so glued to each other that they are almost the same thing. So in the breast, absence of myoepithelial cells means violation of the basement membrane. So if you have a duct and you have an area here that's open, there is no myoepithelial cells, it means that there is invasion in this area. So think of the basement membrane and the myoepithelial cells as one thing for understanding the invasion. Thank God we have specific staining to the myoepithelial cells so we can determine this. So this is to explain to you that 1 layer, we think it's gone through because 1 layer, one of the 2 became clonal at the expense of the other one. But when you have it 2 layers, as I said, whether all benign or we are looking at a big duct loaded with cancer, but not gone out yet. In the breast, we call it DCIS or ductal carcinoma in situ. The principle of 1 layer versus 2 layer is vital. You shouldn't mess with this. This is how the breast, you take a section in the breast, they look like that. This is the lobe, then divided into lobules. And you understand all of the sacs, how they are done. If you have the alveoli balls, you cut through it, you get little circle. Lots of ducts also here. It happened that this duct duct like that, and the cut came through the duct, so we have it like that. You understand that there is stroma between the lobules, as we see here, and if we say another lobule here, there's a stroma inside, but there is stroma in between, and we'll get into this. This is just to give you visualize what we're talking about, because the breast is, I have a little problem with the thick marker is too much for you, right? Can you see this, or is this okay? Because I have a problem seeing it myself with this is too much for you, right? Let's try this a little bit. So we have the sacs here, and this is the alveoli, little duct, big duct, then eventually they open in the nipple. This is a section of the breast, and this is normal. This is how normal breast looks like. And as we say, lobules, and we know now the lobules, the story of the lobules now. And what I want you to learn from this, the lobules will eventually connect into duct, then duct make larger duct, then larger duct, and so on. I want you to know from this that there are two types of stroma here. There is a stroma inside the lobule, and because it's inside, it will be what? Intra or enter? Intra. So we have intra stroma, and in between those, like this area here, it is between the lobules itself. So it's inter or intra? Inter. Why this is important? Because two of the main diseases that will come across occur inside the stroma, which is the intralobular. Then the intralobular is also hormonally active. So the intra, and it makes sense. Why it makes sense? Because they are close to the glands, right? So this is how you memorize it. So the inside stroma is hormonal sensitive. What do we mean by hormonal sensitive? We need to respond to estrogen, progesterone, because this is the most hormone affecting the breast. So let's get the concept of the two layers here. If we take this section here, and even we take this red part here and look here at a large magnification, this one layer or more than one layer, I think it's very obvious. And one should be luminal, which is inside, and one should be surrounding. So this one should be which one? The luminal. Because we have epithelial and what? Myoepithelial. So those cells here are what? Epithelial. Usually they are told columnar, and when they get close to the alveoli, they become little cuboidal. And think of cuboidal generally, think more as a gland, which means the glandular, the columnar becomes short to columnar, they become cuboidal. So cuboidal, think more of gland. You know why this? Because carcinoma of the gland is called what? I heard it, so let's say it now. Carcinoma of the gland. Carcinoma of the squamous is what? Carcinoma of the urinary bladder is what? Transitional or urothelial, right? Carcinoma of columnar cell or gland is what? Adeno. Now you got it. So adenocarcinoma. So connect cuboidal with the columnar. When you hear cuboidal, so you think more of adenocarcinoma. We don't have time for this, but I put it for you. This is how I teach histology right now, by the way. It's all through virtual slides. We have about 40 virtual slides, and you get it in the exam. So please take a look at this, because with the virtual slide, you can look here and say, oh, what is this? You go in, you go out, you enjoy it. Please take 2 minutes. Please try to click it. This is a two-layer principle. When it's two-layer, most likely benign. When it is one layer, it is most likely malignant. And taking consideration that 2 layers, it can be in situ, but still non-invasive. So in other words, when you have one layer, you think more of invasive. And I give you the scenario. Here it is. It happened that, thank God, we have a stain for the myoepithelial cells. And there are many of them, but I would expect you to know this. I give you a few things to know, and this is one of the things. You are required to know that P63 stains the myoepithelial cells. Be easy also for our course that we'll take later, which is a prostate, because P63 also stains the basal cells of the prostate. And we have the same principle in the prostate, but let's stay here in the breast. When you see something like this, we didn't know, sometimes you get a little biopsy and you cannot determine exactly if you are inside the lobule or this is a cancer out in form of lots of glands. So we know that there is keratin stains epithelium, but keratin will stain both epithelial and the myoepithelial. It wouldn't help. But it happened that this P63 stains only the myoepithelial, not the epithelial, which means if it's present, it's benign because the myoepithelial cells is attached to what? Basement what?
Membrane.
Yeah, okay. So if we see that they are present, this means that there is no invasion, that this is benign. So the only thing for a pathologist to look at this and determine if this is benign or malignant, because sometimes cancer can be very well differentiated, very difficult to differentiate, very well differentiated from the active normal. So the presence of second layers tell us that there are two layers here. And as long as we have the myoepithelial layer, so this is non-invasive carcinoma. This is very important, and you see it. I'm not talking about this exams only, in general. And many of your colleagues from the USM even they are keeping communicating with me. And many of these things I highlight, believe it or not, you see it in the USM. In fact, somebody called me specifically about this recently, about the P63. Not only here for the prostate also. This is a slide, yes, you can see it in any exam, but at the same time now you are becoming a doctor. At the same time, I don't think you should know less than first semester. So in the left side, I am showing you the breast and the mammogram of a young patient, and the right side, I am showing you the breast and the mammogram of, I said older, not young person. And let's determine this by premenopausal, postmenopausal, using estrogen as a guide to determine this. I don't think we need to talk much about this because young, more breast tissue. Breast tissue will appear as opaque. Older person, more fat, so it will be more translucent. What we will look for when we do mammography, two things for when we do mammography. We're looking for, number one, mass. Number two, calcification. So why we do mammography, you are looking for, is there a mass or is this calcification? Next is, if there is a mass, what we want to know. Your patient has a mass. What's next you want to know?
Is it benign?
Benign or malignant? And if it is benign, what's the next question? What are you going to do with it?
Surgery.
You have to imagine your patient in front of you. Okay, thank you, it's benign. What's next? If it's benign like this. So whether you give surgery, whether you give hormones, so always connect everything together. So the mammogram, we are looking for mass and looking for calcium. Look at the young lady here. We have no idea what this would be, or this, or this. We don't like what we call speculation. The word is speculation, if you see it in a question, speculated mass. This is cancer until proved otherwise. Anytime in a question scenario, especially in the lung, but in general, speculated means I am thinking malignancy until proved otherwise. So see here, we cannot really determine which one we are worried about, but let's go to the not young persons, all fat, mostly fat, but look here, this area is different, so it can be easily identified. So now, older person in mammograms, easier to find masses. Now, number two, calcification. Okay, somebody came to you and said, or a friend, you are fourth semester student, but you are a doctor to the family and your friends. Oh, my mother has calcification in the breast. What does this mean? And you are stuck. You don't even have any time to go anywhere to look at Google or anything. So calcification, again, exactly like the mass. When we see calcification is actually inside ducts or inside the alveoli, or an older patient, after too much fibrosis, there is some kind of calcification called dystrophic. So this is an older patient, but generally in active breast, and we have calcification, we need to know, is this calcification in benign ducts or alveoli or malignant? Same like the mass. You have calcium, is it benign or malignant? You have mass, it's benign or malignant. So this is what I want you to know. So we will have, this is one of the two things that you will learn about mammogram, and you can have it in exams, which is the age, and I think it makes sense now. In pregnancy now, all the lobules now should now enlarge to start to making milk. So they get crazy, branch, get big, and eventually become really big in preparation for the making the milk. And that's why this is a breast in pregnancy, and see the normal breast. Those are those, but they get expanded. And one of the major problems for pathologists, if you don't know the history, you can have problem, because this is how it looks like. So from this to the left side to this, you see how different? So if you have this and you don't have the history that the patient is pregnant, you can have problem, because this looks very worrisome. And if you take piece of it and look at it, you see, to you don't know that, but it's ugly. The point here is all the cells are now making these vacuoles, and all of this in preparation of making the milk. And here is a duct here, or alveolus, with the milk right here. So the appearance of pregnant or lactating breast is important. You may have one of these images and you have questions around it. Okay, so that's why somebody tell me why it's not malignant. This is too much really at this level, maybe at pathology residency level. It is because it's said that the lobular architecture is maintained. You see here, lobular architecture, that's why it's not malignant. This is for the people who are shooting for the 100. You may have a question like this. The lobular architecture is maintained. The other thing, if we take this and look at high power, although they are ugly, but they don't have the malignant cytologic features that we don't have to list it. But sometimes you can get this in a question, why in lactation is not malignant. Okay, I tell you something. A patient comes to you, she is 32, and she tells you that she had a mass in the breast and she went to sophisticated lab and they give her a report and the images, but she doesn't have the report, she has the images. And she told you, and they showed, and this is the images they sent me on my email. I say it again, a lady 32 come to you, said I had a breast mass, and they took a biopsy. So what I have no idea about the diagnosis, but they send me images, and here's the images, and she shows you this in the computer. What's your next question you ask her?
Are you pregnant?
Here it is. Are you what? Are you what?
Pregnant.
Are you pregnant? Okay. So I'm giving you a concept, a scenario, and you can understand from what all I spoke about here how many questions you can make based on this concept. But I'm giving you the scenario to remember and to understand. If we look at this and count the cell layers, and you say if this is malignancy, is this benign, it is pregnancy, how many layers of cells we'll see here in around each duct? We'll see two. Okay, if we see one layer, we'll be worried or not?
Yes.
Let's say yes. Let's take it one step at a time. So this is a nice slide for your reference. I want you this slide, actually, it's not for the exam, but it is a summary really of maybe the entire lecture. How it's listing all the diseases we are going through it in this lecture that will be today and big part of tomorrow, listing all of them. And what is the normal counterpart, the places where they originate from. And this is very important because here we said that the breast is fibro-fatty. Fatty is the yellow, fibro is the breast tissue and the fibrous tissue. And you said there are two types of stroma. A stroma which is the green, and this green, in your opinion, we'll call it what? Inter or intra? It's in between, so we call it inter or intra? Intra, inside, and here it is intralobular stroma, and in between, yes, it's yellow mixed with the fat, it's interlobular. Here we have what's called the terminal ductal lobular unit. So any unit that have a duct that now collect a lobule, this is called the terminal ductal lobular unit. And this is the main site of cancer. So let's see here. You did it similar to the one I do, by the way. So it's after this slide. We'll do the ding, ding, ding. Okay. Okay, so all of this lesion, cysts, and all of this, all of these funny names, believe it or not, you will know it. We'll go through it in the next part and tomorrow. They arise from this terminal lobule unit. All of those, see, cancer is here. Cancer occur everywhere, but it's mainly here. Then the large ducts here, see the white areas here, you get this stuff, all of these names, vagin disease, duct ectasia, all of this, and we'll go through all of this. They come from the large ducts. Then the inside lobular, this is hormone sensitive or not? The are they sensitive hormone or not?
Yes.
They are. The two main stromal tumor will have, which is a fibroadenoma and phylloides tumor. I mention those specifically because they are very, very popular example, and you know the names, fibroadenoma. Then the interlobular stroma, which is the yellow, which is a connective tissue. You can have all of this funny mesenchymal lesion. Then you have the muscle, and so this is nice for you because we will go through all of that. All of this difficult names, sclerosing adenosis, hyperplasia, atypical hyperplasia, squamous metaplasia, all of those. When you get lost, you come back here or you make your own map to see where they are coming from. It helps. And we'll have 10 minutes, then we'll continue.